So for those of you who don't know, I just want to give you a little bit of background about NAMI. As I mentioned, we are the National Alliance on Mental Illness, and this is an organization that was started by people who had family members who have mental health conditions and felt that they didn't really have anywhere to turn. They didn't know other people that had stories like theirs. So in 1977, they got together and started this organization. So we were very much focused on our shared and lived experience, both for people living with mental health conditions and their families. And our mission is to provide education, support, and advocacy for those people living with mental health conditions and their loved ones. So we do that by providing education. We provide education to youth about, mental illness. What is it? How can it affect you? Where you go when you need help? We provide that education to families and to what we call staff, which would be teachers, coaches, people who are interacting with youth. We also have education for people living with mental health conditions where they can better understand their own condition, how to navigate the mental health system, how to build a support network, how to communicate with their family members when they need help. And we have a similar program for family members called Family to Family, which is a great program I highly recommend. It helped me learn how to navigate the mental health care system, how to communicate with my family members, how to understand and have an eye towards recovery, because living a healthy life, even with a mental health condition, is really our goal. And we have support groups for people living with mental health conditions and their families. And we have many other programs also. So Sophia's going to be posting information about those programs in the chat throughout the presentation. And in addition to that, we ask you to go to namimiami.org and you can see all of the programming that we offer. So let me just check the time here. Okay, without further ado, I want to introduce our speaker today, Dr. Nelson Cordero. Dr. Cordero has volunteered to give this presentation for us, and he also is providing some other volunteer services to us. And we want to thank you, Dr. Cordero, for that. And we want to encourage everyone on the call to, if you're interested in volunteering, there's information. Sophia will be posting that. And we need volunteers who can learn we do all the training, but we need you to possibly facilitate support groups or facilitate educational groups that we have, maybe share your own story. And we have a lot of other volunteer roles. So we'll post information on how you can volunteer with NAMI. The important thing about volunteering is that this supports your own recovery and your own healthy living, your own mental health, by volunteering with us and interacting with people in a very happy and healthy way. So we want to encourage everyone to do that. So let me tell you more about Dr. Cordero. Nelson Cordero Torres, MD, is a caring and experienced board-certified psychiatrist at My Psychiatrist. He was born in Mocha, Puerto Rico, and he understands the unique challenges people from different backgrounds face and specializes in treating addiction, depression, anxiety, and other mental health conditions. He earned his medical degree in Puerto Rico, completed his psychiatry training at the University of Miami, and gained valuable research experience at Rutgers and Columbia University. Currently, he serves as Chief of Psychiatry at Broward Health Medical Center and Vice Chair of Psychiatry at Broward Health Imperial Point. Dr. Cordero is dedicated to providing kind, personalized care to help his patients live healthier, happier lives. And this evening, Dr. Cordero is going to speak to us about trauma. And this is a topic we've had a lot of requests for. So we're really excited to hear this presentation. And if there's other topics you're interested in, please go ahead and put those in the chat. We do ask that you hold questions until the end, questions about the presentation or about NAMI in general. Then put your questions in the chat and we'll go ahead and be asking them. Thank you. Go ahead, Dr. Cordero.
Thank you very much, Susan, for the presentation. I'm very happy to be here today. And definitely this is a topic that is extremely important. You know, what is PTSD and trauma is something that many times we just kind of put it in a box. Oh, if you're a veteran, if you go to, if you had any experience at combat, maybe you're the only person that will develop PTSD, but definitely something that is a little bit more broad. And, with today's presentation, what I want to do is basically give a little bit of a explanation on what PTSD is, trauma, and also at the end, I'm going to be talking a little bit about how to treat the PTSD. Okay, so like Susan explained, all the questions are going to be held at the end, so you can type them down in the chat, or you can write it down if you have a piece of paper, and we can discuss it after the presentation is over. So the title of the presentation is Understanding PTSD, the Signs, Causes, and also Path to Healing. So many times, we talk about PTSD, about something small happening or something minimal happening in our life, and it's very common for us to say, "Oh, I have PTSD from this situation. I have PTSD from that situation." But here, one of the goals is just to define what really is PTSD. So in that way, we can talk about it in a more exact way about what the condition really is. Okay. So PTSD is a mental health condition that occurs after experiencing or witnessing a traumatic event. So this is something that is very important to differentiate, because not only you having experienced a traumatic event can lead to PTSD, but also being a witness of something that is very traumatic can lead to the disorder. Okay. It is characterized by intense, disturbing thoughts and feelings related to the event that persists long after the danger has passed. People with PTSD often relive the event through flashbacks, nightmares, feeling of sadness, fear, or anger, and many times they will avoid situations that will remind them of the trauma. Okay. Something that is very important about the signs or symptoms of the PTSD is re-experiencing the symptoms. Like, what symptoms does a patient with PTSD will have? They will have flashbacks, feeling that the event is happening again, recurrent distressing memories or nightmares, and intense emotional or physical distress when reminded about the trauma. Some of the other signs and symptoms of PTSD are avoiding the symptoms, like avoiding thoughts, feelings, or conversations about the trauma. Okay. Avoiding thoughts, feelings, or conversations about the trauma, avoiding places, people, or situations that trigger the memories, difficulty remembering important aspects of the trauma, loss of interest in previous enjoyed activities, something that is called anhedonia, and also feeling distant from others or emotionally numb after the trauma. Other signs and symptoms are hyperarousal symptoms like difficulty falling or staying asleep, irritability or anger outbursts, difficulty concentrating, be always on guard or hypervigilant, or exaggerated startle response. This is something that we see mostly with patients that suffer from trauma related to war, that sometimes, they are just relaxed and talking to you, and if there's like a big sound, you will see that they can jump or scream, because these kind of situations kind of remind them of the trauma of the combat experience. Some of the signs and symptoms, again, we mentioned that already. So like I was mentioning at the beginning, trauma doesn't necessarily have to be, okay, you're in a car accident, you were involved in a sexual assault, or you were involved in combat. There are different types of exposure to the trauma that can lead to PTSD, okay? So we have like around 4 types of trauma that we want to talk about, okay? The first one is like a complete direct experience, meaning you're involved in a car accident, you're involved in combat as a veteran or active military member, you're involved in any kind of physical, sexual, or emotional assault. So those are what we call direct trauma, something that, like the word said, it happened to the patient. They were the one who lived through the event. They were the ones who survived the event, and they were involved in every kind of the trauma. Okay. We have a different kind of trauma, which is witnessing. That's when you see the event that happened to someone else. What can happen in those kind of scenarios? You are driving, and all of a sudden the person in front of you had a very bad car accident. You witness that. You have to maybe move your car to the side to try to avoid hitting the other car, or you are in a place and someone murder or attack, or you witness some physical, sexual, emotional abuse, those kind of things are the second type of trauma. The third type of trauma, which many times people kind of dismiss a little bit, especially in practice, is that someone that is close to you talk to you about the trauma. And maybe the person that actually had the direct experience, they don't have the PTSD symptoms, but you, just by learning about it, that can lead to PTSD. It's a common misconception many times among psychiatrists that they do not want to kind of validate this because, in their thoughts, they are like, okay, if you were not there when it happened, if you were not involved in any kind of direct way, how can you have PTSD symptoms? That doesn't make too much sense. But, I want you guys to think about a loved one, like a partner, a spouse, children, anyone that is very close to you that come and tell you that something very bad happened to them, like a sexual assault or physical assault, or that you go to a hospital bed, they call you that a family member is involved in a car accident. You have never seen them in a hospital bed or nothing like that, and then you walk into an ICU room and see them in a coma state, intubated, unable to answer, unable to talk. Maybe they cannot even recognize, cannot recognize you when they see you. So those kind of things definitely can trigger a PTSD response. And then repeated exposure. This is a PTSD that is very common between first responders, meaning EMS, firefighters, police officers. Maybe they're not involved in anything, but let's say that you have a police officer that regularly walk into a crime scene and see people that are dead or severely injured in either homicide or car accident. The same thing with firefighters that go and try to extinguish a fire, and they see the devastation in houses like the ones that we saw a couple of weeks ago in Los Angeles. So even though maybe this is not their house, it's not their house that burned down, it's not their family, just going there and dealing with that high amount of stress on dealing with these kind of situations, that can also lead to PTSD. So the last two, like the learning about it, meaning that you hear from the event from a close one, and the one that many of the first responders are related to, many times they get kind of dismissed because physicians do not believe that if you didn't live through the experience, either by direct or witnessing, it's not possible that you're going to develop PTSD. But it's been proven by significant research that that's not correct. So it's very important that, if you talk to someone that if you practice if you're involved in the mental health and you practice, you have to take this into consideration, and it's very well documented. So these are a couple of things that are involved or can count as a traumatic event. One of the most common one is serious accidents like car crashes, motorcycle accident, any fallings. So those kind of things that led to very severe physical trauma, they can count, and many times they are like the main reason for PTSD symptoms. Okay, natural disasters is something that is very common too. Earthquake, floods, those kind of things are also something that led to it. Personally, I'm from Puerto Rico, and even though I was not there for Hurricane Maria in 2017, even today, almost 8 years after the hurricane, whenever I go to the island, I talk to my family, I talk to friends, and we talk about what happened back then. Many of them, they have like maybe not the clinical symptoms of PTSD, but definitely they are still traumatized by the events of Hurricane Maria in Puerto Rico in 2017. Other traumatic events are acts of violence, like assault. It can be physical, it can be emotional. Many times, we do not talk about the emotional part because maybe they don't count. Okay, you were not physically harmed by emotional abuse, but that's something that counts to physical, sexual, emotional abuse. assaults, people that go to war, like active military members, veterans from prior combats, anyone that is experiencing any acts of violence, also that count as traumatic events. Loss or life-threatening illness of a loved one is something that happened, and we saw that a lot during COVID, even though maybe patients were not directly affected by the disease. They didn't have COVID, but just the fact that they had a family member, especially those first couple of months, maybe a family member that contracted COVID and they were in the hospital and they were so isolated with no access to phone or any kind of communication. And you as a person at your home without knowing anything about your family member, I saw, back then, a lot of patients with very similar symptoms of PTSD or acute stress reaction related to having someone that is ill. And not only also with infection, also with patients that maybe have family members with a strong family history of cancer. So they have the mom that died of cancer, maybe an aunt or uncle, and whenever they go to the doctor, they always kind of anxious, afraid that something bad is going to happen to them. So one of the most important things about this slide that I want to discuss is that what can be traumatic for me, not necessarily is going to be traumatic for another person. But it's very important when you talk to a patient and you get that history, try to see, what kind of the threshold of them is to deal with trauma, okay? Because maybe, you have a patient that always, is not a very good driver and keep getting into car accidents and they're kind of used to it. But something like having the mom or the dad or both of them dealing with dementia or cancer or dying, that can be a little bit more traumatic for them versus maybe me, that I keep crashing my car. I grieve in a different way, and that cannot be as traumatic. So something that is very important is that every person is different and they can react to the different situations in a different way, but always to make sure that we understand what can be a trauma for them. So in that way, we can validate how they feel with the trauma. And at the same time, we can see if they need any further intervention. Okay. So here I'm going to talk a little bit about what defines a traumatic event. It's an actual or threatening death, serious injury, or threat to a physical integrity of self or others. Witnessing or learning about events, intense fear, horror, or helplessness, or sudden, unpredictable, and shocking nature. Okay, this is defined by the APA in 2000, and it's something that, even though it's 25 years old now, it's something that still stands. Okay, so here is the tricky part of when we diagnose PTSD. Okay, so like most of the diagnoses in psychiatry, time frame is extremely important. Okay, so you can be involved in a car accident or any kind of traumatic event, and if the symptoms last less than 30 days, and after 30 days or after the month you don't have no more symptoms, then this is what we call an acute stress disorder or an acute stress reaction. So someone that develop an acute stress reaction has all the symptoms associated with PTSD, but they last from the day 1 from the accident or the traumatic event to day 30. If after those 30 days, the symptoms go away, then you do not develop PTSD, okay? So for you to be correctly diagnosed with PTSD, the symptom must persist for at least 1 month, okay? And then after 1 month, the symptoms continue, then you're diagnosed with PTSD. So here we're gonna have like some of key takeaways of what I just mentioned. So PTSD is a treatable condition that stems from exposure to trauma, okay? Something that is very important is that we have to have awareness of signs, symptoms, and how it impacts the ones affected by the condition. I'm going to talk a little bit more about treatment options, but therapy, medication, and community support is extremely important. And also reducing the stigma and encouraging early help seeking can make a significant difference. Something that is very interesting, maybe in the 80s and 90s, like there was like this theory that psychiatrists and psychologists, they were told not to talk to the patient about the trauma until some time passed. Kind of let it heal, let them deal on it on their own, and let's see what happens. But now, like a lot of research have been done on the topic, and as soon as you start treatment, and as sooner as you start determining who need help or who might develop PTSD, that is going to be better for the outcome. So that past stigma about like, do not do anything, do not talk, let them be, is something that is, we don't want to do anymore. We want to, as soon as someone is involved in a car accident or someone is involved in any kind of traumatic event, just go and talk to them and offer the help that they need as soon as possible. Okay? So, something that I want to talk that I think I forgot to put in the presentation is that usually persons that have a lot of trauma in the past, like when they're little, they are more, and they are higher risk of developing PTSD. Around only 7 to 10% of the population that is exposed to trauma is the one that develop PTSD. So, around 1 out of 10 people that have any trauma, they are the one who ended up developing PTSD, which is something that, is significant. Okay. So how do we treat PTSD? The first line that we want to do, me as a psychiatrist, I'm going to talk a little bit more about the pharmacology part, and then I'm going to talk a little bit about the therapy part. But SSRIs are the most commonly prescribed medication to treat PTSD. Okay. In theory, all SSRIs work together. They claim, or the research said, that when you go through intense trauma, the levels of serotonin in your brain decrease. And for that reason, SSRI is the first line of drug to treat PTSD. Okay. In theory, any SSRI can work, but there's some research that back up that two of them have a little bit of a better chance of the patient responding well to it than the others. We have multiple SSRIs, but Prozac, which is fluoxetine, and Zoloft, which is sertraline, are the ones that work the best for PTSD symptoms. Okay. Many times with PTSD, patients can develop a lot of anxiety and panic attacks, especially when, let's say that they are involved in a car accident on 95, and they avoid I-95 all the time because whenever they go through I-95, they're going to think about the car accident that they were involved. So, they will drive 1 hour from Miami to Fort Lauderdale and not the 30 minutes just to avoid I-95. Let's say that they are with a friend and the friend said, listen, this doesn't make any sense. I'm not going to drive half an hour more. If I'm seeing in my ways, then I-95 is clear and we're going to be there in 20 minutes. Not a good friend, but, they drive on I-95. The person that suffered the trauma see the place that they had at their car accident, and they develop a panic attack. They start hyperventilating. They start like feeling extremely anxious. For those kind of situations, despite being on an SSRI, you might need something a little bit more stronger. And this is the moment that maybe we recommend like a low dose of benzodiazepines, such as clonazepam or lorazepam, or Xanax, which it's a little bit more short-acting, Xanax and Ativan. So for those kind of episodes, it is recommended. The tricky part about it is that, as most of you guys know, benzodiazepines can be addictive, and that is not something that you want to add to the problem. So only if you have a patient that you know that is compliant and they're dealing with the anxiety related to the PTSD in a different way, meaning with the SSRI, with the therapy, you might be a little bit more comfortable in prescribing the benzodiazepine. But if not, then try to avoid it. If you have someone with a history of addiction problems or someone with history of alcoholism, just try to avoid it in those kind of situations. Okay. Something that also comes with the PTSD are the nightmares. Okay. And it's one of the most complicated symptoms because they won't respond to the SSRI, meaning the patient is taking the Prozac or taking Zoloft and is doing very well on the medication, but still every single night they have a dream about that person who assaulted them. And it's recurrent, the same dream, doctor. I'm doing well during the whole day. I'm functioning at work. The anxiety is under good control. But out of 7 nights a week, 3 nights I dream about the car accident or about the person who assaulted me, or that I saw the person outside on my work and I didn't know what to do. And these nightmares are not letting me sleep. And at the same time, every night when I know that it's time to sleep, I start ruminating. Oh my God, I'm gonna have the nightmare again tonight. What I'm gonna do? I'm gonna wake up in the middle of the night and I'm not gonna be able to sleep again. So it's a symptom that it can be very disruptive to the patient. So interestingly, how we treat that is with a medication that we use to treat high blood pressure. The story behind the how we discovered that is that many times most of the people that have the nightmares are persons or patients that are involved in combat, like either veterans or active military members that they have blood pressure problems. So at some point they start treating the blood pressure with a medication that is called prazosin, and the blood pressure was under good control, and they start reporting to the doctors that, doctor, you know what, like the nightmares that I was having about the war, they're not as intense anymore, or they even disappear. So that led to some research, and having research demonstrate that that medication, which is an alpha agonist medication, for some reason that is not well understood, it helped with the nightmares associated with PTSD. So that's something that we use to treat the nightmares. Okay, so the PTSD per se, we use SSRIs. For the nightmares, we can use prazosin, which is a blood pressure medication. And for anxiety attacks, we can use a low dose benzodiazepines only in patients that do not have any history of addiction problems. Okay, so that's like the kind of the pharmacological part. Okay, then to me, this is one of the most important parts. Even though I'm a psychiatrist, I always tell all my patients that if I can treat you with no medications, that will be a great success for me, because contrary about like the stigma that we psychiatrists always try to push for medications and we just try to solve everything with a pill. I know through my experience, I've been doing this, if I count residency, around 15 years. Therapy is extremely, extremely important. Okay. And not all the problems are solved with a pill. And like many times I tell my patients, the medication that I'm going to prescribe you is going to do 30% of the job. You have to do 20, that with the follow-up, you have to go with the therapy. And, some of the things that I maybe tell them after I identify what's going on with them. You have to take this measurement at home. So you have to deal with your son or daughter in different way. You have to try to do these things at work. So therapy and the behavioral part of how we handle things, it is extremely important. And with PTSD is one of the most important things. Like I mentioned earlier, uh, as soon as the accident happened, if you know that a patient have a history of prior trauma, you have to be hands-on with that patient. You have to be and try to identify the problem as soon as possible, because like most of the medical issues, the soonest that you start treatment, the better outcome you're gonna have. Okay, so there are a couple of psychological interventions that we can try. Okay, and the first one is trauma focused cognitive behavioral therapy. Okay, what is this? So this means that very slowly and gradually we have to start exposing the patient to the trauma. Okay, and it's not that you're gonna, if the patient were involved in a car accident, you're gonna say, okay, come drive with me, and I'm gonna drive 100 miles on 95, and you will see that we won't be in a car accident. Okay, so how do this work? Is that you have to expose the thoughts, the feelings, and the situations. Okay, for example, someone is involved in a car accident and they are afraid to drive, and they're afraid to go with a friend and drive on 95. So how you do? You don't go ahead and start driving, like I mentioned before, driving like reckless. So he said, okay, we are here in the office. So next session, what we're gonna do, we're gonna relieve, or we're gonna redo everything that you did the day of the accident. Okay. And then how you expose that? He said, okay, so they come to the office, you're gonna tell them, close your eyes, and let's think that we are driving from Miami to Fort Lauderdale with them in the car, with them in the office, and then you kind of relieve. Okay, so go to the kitchen, grab your keys, and now we're gonna walk to your car. So slowly you go and you kind of expose the patient to the situation or feelings. Okay. At the beginning, even though they know that they are in a safe environment and that they are in a structure, they might feel very afraid. And you're gonna see that they're gonna be like, "Oh, doctor, I don't feel safe. Doctor, do you think that this is right? Let's stop this." And especially with more intense trauma, in combat trauma, cases of physical sexual abuse, when you try to, expose, even though it's in a safe environment, the patient to these kind of situations, it can be very scary. And it's something that it will take time. You won't be able to do it from the first time. You need to do a couple of sessions of them, trying to relieve or trying to experience that again, and it can be very traumatic. Okay. At the same time, you're gonna try to teach you specific techniques, or you give them homeworks. Like I said, the same example of the car. Okay, you don't want to drive, so you haven't driven for the last 3 months. So today we're gonna drive 5 minutes. You bring your mom, bring your dad, bring someone that you feel safe, and slowly you're gonna start going back to the routine. Okay, so that is one of the most effective techniques. Is the trauma focused cognitive behavioral therapy. The tricky part about it is that you have to give homework to the patients, like for example, the one that I said, drive 5 minutes today, then wait 2-3 days and drive for 10 minutes. So those kind of things. So the patient need to be very involved, and the patient need to follow the directions. Okay. Something that is also very important in the trauma-focused CBT is trying to identify the upsetting thoughts about the traumatic event. Because maybe, when that happened, you can kind of point more into that. Because maybe the traumatic event for them is not being involved in the horrible car crash. Maybe the person was driving by themselves, they will never develop PTSD. But the PTSD comes from, oh no, my daughter was in the back seat, my wife was next to me, and while everything was falling in the car, in the crash, I'm not thinking about, okay, something bad is gonna happen to me, I'm gonna die. I'm gonna be thinking about, oh my God, something's gonna happen to my daughter, something's going to happen to my wife. So those are the things that you have to identify. Okay, so out of this traumatic event, what was the thing that upset you the most? What was the thing that was more frightening to you? And those kind of things, then you try to work with them. Let's say that, oh, I thought that my wife and my daughter was what, they were gonna die. So I said, okay, why was that traumatic for you? No, my daughter is very small. I love my wife a lot. She, without her, I don't want to be alive. So, okay, so you can try to work in that area about maybe losing someone that you love rather than just putting all the focus on, okay, you were in a car crash and you were thinking about the possibility that you might die. That person said, listen, if I die, I die. It is what it is. But the other part is the one that was upsetting for me. So also that is very important to kind of identify in the trauma focused CBT. Okay. Then we have the exposure therapy, which is the one that is a little bit more intense because in the trauma focus CBT is not that, you just kind of guide the patient in a slow way. In the exposure part, it's a little bit more aggressive, meaning that if the trauma is related to the LA fires and your house burned down, you go with the therapist or the psychiatrist to the place. Say, okay, listen, tomorrow we're not meeting here at the office, we're meeting in front of your house. It's a little bit more aggressive because maybe the patient is not ready to do that. Maybe the patient, just the fact of thinking that that will happen the next day, that will trigger some of the symptoms, but it's another approach that you can have. Okay. Before you kind of expose the patient to the trauma, you kind of let them with a little bit of imagination games, a little bit, but then you return to the site. And that is a little bit more fast than the other one. Okay. Some of the therapies, some of the literature said do it gradually, but when you're gonna practice exposure therapy, it tends to be a little bit more aggressive, like I mentioned before. Okay. And then we have the cognitive restructuring therapy, which involve like identifying irrational thoughts, but at the same time they're understandable. For example, these patients believe that every time that they're in a car, they're gonna get in a car accident. They believe that someone let's say that when they were sexually assaulted, the person was wearing jean and a white shirt. They believe that every person wearing a white shirt and a jean is gonna sexually assault them. So when you see a patient that the symptoms are so severe that it tends to be a little bit of irrational, even though you need to validate those symptoms because the symptoms are real and understandable. But what are the odds that every time that you get into a car, you're gonna get into a horrible car crash, or if you were sexually assaulted by someone with a white shirt and a jean, every person wearing a white shirt and a jean is gonna assault you is extremely likely. So in that kind of therapy, you have to restructure and replacing all these dysfunctional thoughts with something more realistic and helpful ones. For example, let's say that you're in a you're going with your significant other or a friend to a fashion week, and the designer that is presenting the collection is the white collection, and all the models that are gonna go through the runaway, they're gonna wear white shirts and jeans. You're gonna say, listen, this is extremely likely that all the models are gonna assault you. This is more of a trend topic, it's something more trendy with this specific designer. So let's go and enjoy the show, and it doesn't have to worry about that. Many times the patient are gonna be saying, "Oh, doctor, you know what? After this, I will never be normal again. I'm gonna die." So you how you're gonna respond or answer to that is more with positive reaffirmation, like, listen, it will get better. It will just take time. It sounds a little bit of a cliche in psychiatry and psychology, the one day at a time kind of things that we tell the patients. But I would say that in all of our conditions, unless someone come up with a medication that will help all the symptoms in days, it's a process of one day at a time. SSRIs take between 6 to 8 weeks to work. Therapy take months or years to deal with things that happen to us or things that specific trauma that we're having. So it's a constant battle. So it's something we always have to be reassuring the patient. Listen, it will get better. It will just take time. Come to therapy, take your medication, follow up the treatment plan, and you will see that things are gonna get better. Okay. And those are like the most common types of therapies that we use. We talk about the therapy, we talk about the medications, and I think that's we have around 12 minutes, so I think that we can stop here and see if we can answer some questions.
Thank you so much, Dr. Cordero. That was very informative. We did get a couple of questions in the chat, and if anyone has other questions, right now I have 3 questions. We're going to go ahead and ask these, and if there are more questions, please go ahead and put your questions in the chat. Wait, let me change my chat settings so I can see. Okay, so we're going to start with, so many of the people that are involved with NAMI, they're either someone living with a mental health condition or a caregiver for someone living with a mental health condition. So one of the questions that we had is, can caregivers of people with mental health conditions, be it a child or their adult child, if they witness them behaving irrationally, having a psychotic break, say having a panic attack, can that create trauma for that parent or that caregiver?
Absolutely. Absolutely. It's something that we see very often. You know, I do mostly inpatient, and it is one of the hardest things to me to deal as a psychiatrist today. Doesn't matter how many times it happened, is that first break of psychosis. Because the patient parents come to me and say, listen, you know, what's going on? You know, my son, my daughter, my boyfriend, my girlfriend was completely fine until 3 months ago. What happened? You know, now he's aggressive, he's paranoid, he's not talking to us, he's not taking care of himself, he don't want to come and look for help, he doesn't want to take the medications, and that create a lot of burden in the family, especially, you know, when the family care about it, you know, because sometimes we have some patients that, you know, because of the family dynamics, maybe the family is not that involved, but for family that is, they're caring, they're involved, and many times it's a little bit difficult to understand what's going on. That can definitely create some symptoms, and especially let's say that they bring the patient to the hospital, patient gets stabilized on medication, they're very happy, they have their son, the daughter back, they go home, they stop taking the medications, and they start seeing the signs again of another episode. That can definitely trigger some traumatic symptoms. Absolutely.
So let me ask, when that happens, I mean, that's one of the reasons that we have support groups for family members and caregivers, so that they can meet with a group of people who have had similar experiences and talk about it openly. So when you're talking to someone else who's witnessed something like this in their family, it doesn't seem strange, it doesn't seem weird or off. It's normalized within these groups. Is that a part of a therapeutic solution to experiencing that trauma?
Absolutely. And in these kind of cases, support groups are extremely, extremely important, because many times we are so worried about, okay, is he or she taking the medications in the morning? Is she taking the medications at night? I have to go to work, and maybe he's not ready to go to school or work. What is he doing at home? And many times these family members, they kind of isolate, and all their life revolve about medications in the morning, medications in the afternoon. I'm worrying through the whole day about what's going on with my loved one at home. Uh, and we think that I'm the only one going through this. There's no one else going through this, and that can put a lot of pressure, leading to depression or anxiety to the family member of someone with that is mentally ill or dealing with mental illness. So definitely that's something that support groups, they are extremely important, because you can hear from other people, I'm not alone. This is something that other people go through. How do you deal with this? I do A, B, and C. That worked for you? Yes. Okay, I'm gonna try it because I've been doing D, E, and F. Oh, that worked for you? Sometimes. Okay, so that support of family members is extremely, going through the same thing is very important, because many times the family member, they believe that they're the only one going through that, and just listening that they're not alone, just that alone is very helpful.
Well, that's great. Great to hear. So I can say, like, for me, a late night phone call. If my phone rings late at night, I become very anxious because I've had enough traumatic experiences with family members. So, and so I have found that the NAMI groups are very helpful for me. Now, talking about people who are living with mental health conditions, sometimes people may have a psychotic break or have some other episode where they find themselves involved with either the police, they may get arrested, or Baker acted and committed to a psychiatric facility, and sometimes against their will. And so the question is that traumatic for them, and how does that trauma affect their the primary mental illness that they're dealing with? And then these repeated traumas, what kind of impact does that have?
Yes, definitely something that it can be traumatic, especially if it's someone that, for into a certain way, have never had any kind of issues with the law, that is not familiar about what's really happening, and all of a sudden the police show up at the house. They believe that they're doing nothing wrong, but the mom or the dad or whoever is living there said, listen, this has been going on for a couple of days. I'm afraid that he's going to do something against himself. Afraid that he's going to do something against someone else in the family. And the police, sometimes multiple police cars show up. Depending on the state of the patient, they might handcuff the patient, take him away like he's a criminal. And that's something that cause trauma to the patient and can cause trauma to the family. I always said that this kind of situation is one thing's resolved, meaning that the patient goes through the inpatient admission and he is stabilized on medications or therapy, and he come back to the home, to home. It's very important just to use this as an educational part, not only for the patient, but also the patient for the family. To say, listen, now that you're more stable, let's talk about the day that the baker acted you. What was going on? I don't know. I was angry. I was frustrated, and I know that I shouldn't be banging my head on the walls. And I know that I don't know why I took the knife and I said that I was going to cut myself or that I was going to hurt you. Okay, so it is extremely important that for this not to happen again, what's going to be our plan as a family? Are you committed to go to the psychiatrist every month? Are you committed to talk to a therapist? Are you committed that if they're here, and most likely they're involved with NAMI, and you guys have so many things and many opportunities. So as a family, what we're gonna do to avoid this to happen? Okay, we have NAMI, they have multiple resources. Are you gonna go to the doctor every month? Are you gonna go to the therapist every week? Because we don't want that to happen again. How do you feel when the police came, handcuffed you, and took you to the hospital? No, it was very bad. I'm not a criminal. I don't know why they treat me like that. So try to use it more as a learning experience for everyone, and come up with a plan out of the traumatic event. And also, it's very important to reassure and ensure them, listen, I call the police, not because I don't want you here, and not because I believe that you're doing something wrong. It's because the situation escalated to a point that I couldn't handle it anymore, and it was not safe for anyone. So for your best interest, and for the best interest of the family, we had to do that. But now that you're here, let's come up with a plan. So use it as an educational experience rather than a punishment. I think that's something that can help.
Okay, that's interesting. And I know I sound like a broken record here, but we do have support groups for people living with mental health conditions. And so for them to be able to talk to each other about their own experiences being Baker acted or being arrested and be able to talk about it in that safe space could also be healing. We have an important question here I want to make sure we get to. How does management of PTSD progress over time with failure / non-response to initial therapies?
Okay. So right now, they are, I think that if there's a moment of transition, it's now. Okay, because beside the typical SSRI, the ones that I mentioned in the presentation, there are a couple of new techniques that to a certain degree do not involve medication that can help. Right now, there's a lot of research trying to use TMS to treat PTSD. Right now, we use it for depression and anxiety, and it's something that have been extremely helpful in treating both.
TMS, can you,
Yes,
what is,
TMS is the acronym from transmagnetic cranial stimulation. Okay, it's a treatment that basically use magnetic wave, kind of to put a simple massage the area of the brain that is in charge of producing serotonin and norepinephrine. So you go to an office, it's a painless procedure. You go, the tricky part, you have to go every day for 20 days. So it's a month treatment. You go Monday to Friday, and you can, 20 minutes, you are in and out of the psychiatrist's office. And that for depression and anxiety is been working extremely well. Many of the patients that go through the treatment, if they're taking 3 antidepressants, they cut it to 1, or some of them, they even stop taking all medications. But right now, there's a lot of research trying to use TMS to treat PTSD, which I believe in the next year or maybe less, it will be FDA approved. Okay, so that's one option that we will see a big change and a different option, an alternative to medication that we'll be seeing in the next couple of years. There's another thing that they're working mostly in Europe with psilocybin, which is the medical mushrooms. There are a couple of states right now in America, in the United States, that have legalized it, and they're doing some studies, but most of the data is coming from Europe. And it's another promising treatment for PTSD and depression. That one, I think that it will take a little bit longer because mainly of the legality of the treatment option. Okay, still is categorized as a recreational drug, but in microdosing or lower dose of the treatment have proved to help a lot with PTSD. So that's something that is also new. So those
we
two
have,
things. Mhm.
Dr. Cordero, we have a question also about somatic therapy. Is that?
Yes, somatic therapy that involve more some of the patients that go through the trauma, maybe they don't have like the typical symptoms and they express more with medical complaints. So kind of address the complaints, constant reassurance is something that can help too.
Okay, that's interesting. Let me just make sure, let's see if because we're at time, although we did start a little bit late. What is the best way for me, a non-professional, to help a close family member with PTSD? That's our last question for the evening.
The most important thing is be there for the family member, be supportive, and try to let them know. If it's someone that is willing to get help, that's ideal. So be there, be supportive. If they have a therapy appointment, listen, can I drive you today? If they say, oh, I want to talk to you, I'm not feeling that good today, just be present. If it's something that have the condition and is not very open to treatment, just kind of be present, but be suggestive, like, listen, can you see that before this event you were, let's say, playing basketball every other day with your friends, and after that you haven't played basketball? What's going on? No, I'm not feeling like playing basketball anymore. So why? You used to enjoy it a lot. Why do you don't maybe try to seek some help so you can start enjoying things that you used to like in the past? And those are like the most important things. Be present, be supportive.
Fantastic. Well, thank you so much, Dr. Cordero, and thank you to everyone who joined us. We just want you to go ahead and feel free to reach out to us at NAMI if you have any questions about the presentation this evening or any of the information that was posted in the chat. We have a helpline that if you have any questions about anything related to mental health and mental illness, where can I find a provider? Is this an issue I should be concerned about? Or if you're having issues and just want to talk to someone, we have trained people that answer our helpline. That number's been put in the chat. You can call that number at any time. And there's also an email on the website that you can, if you don't want to talk to someone, you can send us an email. But whatever it is that you need to do to take that step to get the help you need or to help someone you love get that help, we are here for you. And we hope you'll contact us. And thank you again, Dr. Cordero.
You're welcome, and have a good evening, everyone.